In this video, I'd like to describe for you our current technique for the treatment of pre-existing astigmatism at the time of lens-based surgery. I am a medical monitor or scientific advisor for the following companies. However, I have no financial interest in any instrumentation and specifically no limbal relaxing instruments that will be shown in this video. Before we get into the surgical technique, however, I'd like to address three questions. First of all, do we really need to be correcting astigmatism at the time of lens-based surgery? For exactly which patients? And how do we go about doing this? I ask this first question rhetorically just to point out that according to Dave Harmon's market scope in this pie chart shown, over half of surgeons today are still not actively addressing pre-existing astigmatism at the time of their implant surgery. We have learned, of course, from our keratorefractive experience that as little as 3/4 of a diopter of astigmatism will leave patients with glare and halo and symptoms. So as such, we are trying now to leave patients with as little as a half a diopter of both sphere and cylinder. We can go about treating pre-existing astigmatism in three ways. The first would be an incisional approach, and today that has become mostly limbal relaxing incision, or utilize a toric IOL, but unfortunately here in the United States we have limited designs. And lastly, we can utilize excimer laser technology. With regard to the choice of technique, I believe it will depend upon 1. Surgeon comfort level, 2. Specific patient considerations, and thirdly, clinical contraindications. I am admittedly a limbal relaxing incision guy, and for that I have to thank Dr. Spencer Thornton, from whom I have learned just about everything I know about astigmatism correction and incisional surgery, as well as other pioneers, including Dr. Dick Lindstrom and Dr. Dave Dillman, who first introduced me to the technique of limbal relaxing incisions based upon the work of Dr. Stephen Hollis. With regard to specific patient considerations, we look at one's age as well as the amount of cylinder, and I feel very comfortable correcting up to 2.5 to 3 diopters of pre-existing congenital astigmatism through the use of limbal relaxing incisions. For levels greater than that, then we often combine techniques, that is to say a toric IOL and limbal relaxing incisions and or even excimer laser correction. There are certain clinical contraindications, however, to the use of an incisional technique, for example, that of irregular astigmatism, and as such, corneal topography screening becomes very important, as well as prior corneal surgery. In these cases, a toric IOL would be ideal. Ideally, one should be able to avail themselves of all of these options to correct astigmatism. Moving over to the actual technique itself, I'd like to stress 4 key points. As with any astigmatic correction, proper centration is of utmost importance. Pictured here to the right is a 6 o'clock ink mark, typically used by many surgeons. However, I have come to believe that placing 4 radial marks on the cornea as orientation points is much more helpful. Using vernier acuity or a linear hyperacuity sense, we're able to much more accurately find the steep meridian using something like a Mendez gauge off of these 4 radial marks compared to a simple single limbal mark. The second key point is that these incisions are actually placed in the peripheral most extent of clear corneal tissue. As such, they're actually intralimbal and not limbal incisions. These are very peripheral clear corneal incisions. If one does incise at the true surgical limbus, we see a marked decrease in effect, hence much of the regression and undercorrection that some surgeons have experienced over the years. Also, these incisions must be placed perpendicular to the corneal surface, as taught by Dr. Thornton and other pioneers in the field of incisional keratotomy. Too often we have the tendency of placing the diamond knife perpendicular to the operating room table or the floor, and we end up with a more beveled incision, again leading to undercorrection and inconsistent results. The fourth and last point is that it's very important for these incisions to be deep and clean and of a high quality. For me, that requires the use of a high-quality diamond knife, and in recent years we've taken to performing ultrasound pachymetry over the intended incision site and using an adjustable diamond based on corneal thickness in conjunction with a refined and updated nomogram, which we'll talk about a little bit further, and I would be happy to share with anyone who's interested at the following email address. The current Napa Nomogram that we use for all of our pseudophakic patients has essentially replaced our original limbal relaxing incision nomogram that was used with cataract patients. The Napa Nomogram was actually used early on with our younger keratorefractive-based patients who received limbal relaxing incisions in conjunction with LASIK or phakic IOLs. We then began to gradually replace the original phaco LRI nomogram, which used an empiric 600 micron blade depth setting, with the Napa Nomogram, for example, for patients who were receiving refractive lens exchanges, and then with the arrival of presbyopia correcting IOLs, because we found that the Napa Nomogram was just slightly more accurate, and taking the time to measure corneal thickness was indeed worth it. Today, we use the Napa Nomogram for all of our pseudophakic patients. As you can see, the Napa Nomogram, we use the left-hand column to find the amount of cylinder that we are going to correct, and then we slide along the right-hand column to the patient's particular age. The arc length is expressed in degrees of arc, and these are all paired incisions. And notice at the bottom that the blade depth setting is adjusted to 90% of the thinnest pachymetry reading obtained. This may need to be further adjusted based on the particular diamond blade and surgeon's technique that is used. The nomogram differs slightly for against the rule astigmatism. Prior to addressing the actual technique, we need to consider our measurements, and unfortunately, in many cases, the various refractive and corneal measurements turn out to be disparate, and it can be very confusing as to what exactly we want to correct. Traditionally, one would use astigmatic keratotomy or even toric IOLs to correct that amount of astigmatism that is measured by conventional keratometry. The assumption being that any difference between refraction and corneal K readings would be attributed to lenticular astigmatism. I would submit to you, however, that measuring everything, as many parameters as is possible, can be useful, and then we essentially throw out outliers, low and high readings. Certainly on patients that have dense cataracts, the refraction may not be reliable, but it can be, in other cases, helpful to sway us in one direction or another. And increasingly, we come to rely today more and more upon topography. But essentially, we make and take an analytical blend of all of these readings. When getting started with limbal relaxing incisions, a few additional considerations I think are important. Perhaps beginning with patients who are receiving traditional monofocal lenses would be beneficial in that the patient's expectations may not be quite as high. Similarly, very dense cataracts or ametropes will certainly be more pleased with a given level of result. And I find it helpful in teaching this technique to surgeons to begin with patients who have a moderate amount of astigmatism and whose measurements are consistent throughout. Good anatomy and specifically good exposure is important, and we certainly want to be comfortable with our first few cases, and one might consider utilizing a block and similarly not charging the patient for this technique. The technique really begins in the holding area where we apply the orientation mark, and as indicated, rather than using a single inked mark, my technician here is using a 4-cut or 4-ray marker to better allow us to judge the orientation and find the exact meridian over which the limbal incisions will be placed. This is a pendular instrument made by Rhine Medical, Mastel Precision, and other companies have similar instruments for this. In this first case, we're going to demonstrate the correction of with the rule astigmatism at the 100-degree axis. This is a left eye, and I am sitting temporally, which is at the bottom of the screen. We place the Mendez ring gauge over the orientation marks, which initially are hard to see, but as the cornea dries, we'll see the 4 non-inked radial orientation marks. And we're placing an inked mark over the steep 100-degree meridian. This second ring is used to delineate the extent of arc to be incised, and the 0 point is placed over the steep meridian, and then this modified 2-cut RK marker is used to ink the cornea. In this case, we're delineating approximately 50 degrees of arc as dictated by the nomogram. And notice again, we're intentionally allowing the corneal surface to dry so that the ink marks do not run. We now will wet the cornea in anticipation of pachymetry measurements. Depending upon the arc length, 2, 3, or even 4 readings will be taken over a given incision site just inside the surgical limbus where the incision will be created. These measurements certainly can be taken preoperatively in the office or clinic setting. I often will do these on the table, double gloved, with the pachymeter wiped off very carefully using alcohol. The diamond blade is set initially to 0, and the blade is confirmed to be flush with the footplate. We then advance the micrometer to 500 microns once around, now 600, and a little bit further to approximately 675 microns, which is 90% of the thinnest reading that we obtained. I prefer to cut on a slightly moistened cornea. I like to fixate the globe with this modified fine Thornton fixation ring. Exposure is very important, and the fixation ring allows us to move the eye. All incisions on the left side of the globe are created with my left hand. The fixation ring is held in my right. And as you can see, the incision is clearly within clear corneal tissue. And these incisions are placed irrespective of the vascular pannus, but rather just inside of that initial gray-blue limbal transition zone. The instruments have been switched. The fixation ring is now in my left hand, blade in my right, and I prefer to pull the diamond toward myself, toward my body, twirling the blade as it is advanced between thumb and index finger. Notice we stopped in this particular incision because we started to see some epithelial drag. One can certainly come out of the incision and then reinsert the diamond, thus negating the pulling off of a large sheet of epithelium. Also notice that the side port incision for my non-dominant right hand was placed outside of the extent of the limbal relaxing incision. We do not like to have those incisions intersecting. And then finally, the temporal clear corneal incision is placed in a single plane fashion. In this case, we can more easily see the non-inked radial orientation marks because of an excellent red reflex. This patient, again, has witherul astigmatism, and this Mendez gauge is a prototype. It's a little busy, but we're going to align the 90-degree mark over the 6 o'clock radial orientation mark, and here the patient's astigmatism is at the 85-degree meridian, so we mark just off to one side of the 6 and 12 o'clock orientation marks. This ring is used to delineate the extent of arc, and according to the nomogram, we're going to mark off approximately 60 degrees, 60 to 65 degrees here. Now, there are a number of different marking instruments that can be used. Every major instrument manufacturer has various instruments, so there are a lot of different ways of accomplishing this. This is simply the technique that I have adopted over the years. I find it to be facile and quick. We're now going to take pachymetry again, this time approximately 3 points, and we'll use the thinnest reading obtained and then set our diamond blade at 90% of that measurement. Not all pachymeters work well peripherally, so one has to be sure that they have an appropriate instrument. We have zeroed the diamond micrometer, and we'll now advance to the 0.5 mark, which is 500 microns, 600, 670, 85. Now again, the diamond blade is in my left hand. Fixation is occurring using my right hand in the fixation ring, and then we'll pull the diamond toward ourselves using the limbus as a stencil. The diamond blade or the foot plate does not ride up against the inner aspect of the fixation ring. And notice the foot plate is on the outer aspect of the diamond. The foot plate itself is curved to correspond to the radius of curvature of the limbus, so that the way in which the knife is held and advanced should be obvious. Now the instruments are switched from my right hand to left hand, and the fixation ring, by the way, as you can see, has 10-degree incremental radial marks, so the fixation ring can also be used to help assure that we are creating an appropriate arc length. At one time, frankly, I did not always ink the cornea. Here you can see we're exiting several times, again to avoid epithelial drag and creating a large abrasion. Also notice that this limbal relaxing incision was placed a little more centrally to allow me to, in this case, place my side port outside of the LRI. So one can either move the side port incision beyond the extent of the LRI or place it more peripherally. In this third case, we have a patient who has against the rule astigmatism at axis 008. So we'll delineate with this ink mark the steep meridian. And what we basically do is find a limbal landmark as we hold the Mendez gauge over the limbus, fixate our vision on that limbal vessel, and then mark it as the gauge is removed. This second ring now is placed with the 0 mark over the ink mark, and the nomogram is calling for 35 to 40 degree arcs. A very typical case, as so many cataract patients present with 1 to 1.5 diopters of pre-existing astigmatism. And we'll note in this case, as opposed to the following case, that the temporal arcuate limbal relaxing incision is created to its full arc length. That can be done as long as the arc length is at or less than 40 degrees. For longer temporal arcuate incisions, that is to say for longer incisions through which the phacoincision must be created, we worry about wound gape intraoperatively. And as we'll see in the next case, the temporal arcuate incision is only made to a partial arc length initially and then extended near the completion of surgery. Here, once the pachymetry is taken and the diamond blade is adjusted, we're going to create the temporal arcuate incision to its full arc length. First, however, we'll place the nasal LRI, and nasal access can be difficult in deep-set eyes or patients with narrow palpebral fissures, and for that reason we always use a locking speculum and take great care to improve our exposure and access. Again, the fixation ring can be very helpful for this, and under topical anesthesia one can certainly ask the patient to look in one direction or another. That affords us the ability to maintain a perpendicular orientation with these incisions. Now for the temporal arcuate incision. Again, one can use the fixation ring to stabilize the eye and to help delineate the arc length based on the 10-degree incremental marks. The side port is fashioned. Here we're moistening the cornea with some sterile lidocaine gel. And I do firm the eye up with intracameral lidocaine, not viscoelastic, prior to keratome entry. And the technique for creating the phacoincision through an LRI, where the two are superimposed, is to place the keratome into the LRI, parallel to the plane of the iris, in advance. I here prefer to place that keratome up against the left side of the LRI since I am left-handed. Now, in this next case, we'll see limbal relaxing incisions placed over the steep 140-degree meridian, and because of the arc length, we will not create the temporal arcuate component to its full arc length at the outset of surgery. Again, if we did so, we would see undue gaping of the incision due to torque and stress from the phaco and IA instrument. So rather, we will create a partial arc about the width that corresponds to our phaco incision and then extend it further. Again, this is important when the phaco incision is placed through an LRI and the arc length is going to be greater than 35 or 40 degrees. And as you can see in this case, the incisions are centered over the 140 degree axis and we're delineating approximately 60 degrees of arc. The nasal incision can certainly be created to its full arc length, but the temporal incision will only be made in part initially. So following pachymetry and adjustment of the diamond micrometer, we're going to pull the eye toward us, exposing the nasal limbus, and we'll begin the incision. In these longer incisions, it's common to have to exit and re-enter. Again, we are cutting with essentially no real attention toward pannus or the vasculature. Bleeding will stop spontaneously, but rather these incisions should be placed in the peripheral most extent of clear corneal tissue just prior to the point where we see the transition to gray-blue tissue. Now, the temporal component will delineate approximately 25 or 30 degrees, which corresponds to my current phaco and IOL incision size. The diamond keratome is then placed into the mid-depth of the LRI and advanced parallel to the plane of the iris. Following phaco and INA, the capsular bag is refilled, the eye is made firm, and at this point we complete the temporal arcuate incision by placing the diamond LRI blade back into the prior deep groove, if you will, and we extend the LRI out to its full arc length. The internal aspect is then slightly enlarged and the lens is placed. In conclusion, I think it is very fair to say today that astigmatism management has indeed become an integral component of modern IOL surgery. The contemporary phacosurgeon ought to be able to avail themselves of several different techniques, including limbal relaxing incisions, toric IOLs, and excimer laser technology to address pre-existing as well as residual refractive error. And I feel strongly that these techniques do indeed fall well within the purview of all contemporary anterior segment surgeons. And I hope very much that this video will be of help to you when performing limbal relaxing incisions. Thank you very much for your attention.